committee. So it's a great pleasure to be here in Turkey again. It's my first time to be in Gaziantep, a lovely city, and I hope to have time to see something in it. A warm welcome as well from Cardiff University, where I am affiliated with. Cardiff University is one of the oldest universities in UK, for over 140 years old as a university. My topic today is about the diabetes and Ramadan. Of course, we have many people who enjoy Ramadan and enjoy fasting. We also remember that fasting over the next number of years, as well as current years, is long hours because of summer days. So average in many countries could reach, where I am in Europe, to 18 hours. I guess in your region might be around 15, 16 hours. However, the weather in your country will be warmer than Northern Europe. So fasting during Ramadan is a difficult task for the healthy, able person. And consequently, it could be a tasking job for a person with diabetes. Of course, the Quran and the teaching of the Prophet Muhammad ﷺ exempts many people from fasting, exempts any person who is a child or ill or traveling, a pregnant woman, a woman during menstrual cycle, as well as, of course, any person with other medical conditions or indeed with mental incapacity to fast. Having said that, many people who are Muslims, they would like to fast despite the advice of their health situation from their clinicians. So what can we do? This is very variable from country to country. If you Okay. If you look into the variability of fasting in type 1 diabetes in many countries, for some reason it doesn't like that slide. Let me just try to... Maybe just skip that slide if you wish. Go to the following slide and I will talk about it verbally in case there is a problem in the slide. Okay, until we saw this, I can talk about it verbally. The data of the EPDR study, which is a study that was conducted in 2001, looking into 11 different countries. And they looked into the epidemiology of fasting during Ramadan. And this data looked into type 1 as well as type 2. And it is interesting that the variability between Morocco and Saudi Arabia is about 9 times different. In Morocco, 9% of people with type 1 diabetes fasted. In Saudi Arabia, 72% fasted, or 70% fasted. Same year, same country, same region, and same type of diabetes, which shows the difference in advice from one country to another country. In type 2 diabetes, the situation was less variable from country to country. In Turkey, the data says about 56% fasted, while in Malaysia and Bangladesh, it was 90% who fasted. Now this is all data that was collected in November, so winter months, like this month, which is different than Ramadan of this coming years in June and long summer days and hot as well. So we need to try and do something regarding this. And I hope that we also try to do something regarding the computer, the slides. I can carry on without that, but I think you need to see what we're talking about as well.
Yeah, Mohamed, we need your professionalism. We had a little bit technical problem. because away, so keep talking for about 3.5 minutes.
Okay, maybe that you have in your brochure about Ramadan. This is important information for us to try to understand the views of everyone here, which is a very good representation for people with interest in diabetes. Whether you're a patient, whether you're a diabetologist, a pharmacist, a dietitian, a nurse, a psychologist, a scientist, it would be nice to know your views, and they're only a circle which will not take too much time. So maybe that's an opportunity for completing the questionnaire. There's two versions, English or Turkish. Fill in the one that you prefer.
Perspective, your views are very important. Please have your sheets on and start answering. There is no wrong answer. There is no wrong answer. There is no reward, but there is no wrong answer, okay? Program. So, why is it important that we need to work on diabetes and Ramadan? 10 years ago, I know that I have, but they have 700 milligrams per deciliter of sky-high blood sugar numbers. But these days, it changed. They have by diet control diabetes. That means their highest number, even after a very heavy, strong supper, like say 175, they say, I don't want to fast. So they want me to be in between themselves and their decision and the God, I mean Allah. So you understand what I mean? The patient perspective is changing. They have the ability to fast, but they want to put me between them, their decision, and the God. So it changed. Before, they were coming to my office with tears because I have the responsibility. I have no issue with the Ramadan because I fasted all my life. I will be punished in front of Allah on doomsday. But it changed. This is my perspective. So what do you think? Or the other question is, why are we keen on working on diabetes and Ramadan? Why?
Okay, let me point. Why, if you're a Muslim person, that's a month a year, a month of every year of your diabetes. So it's a big proportion of your life. And obviously because of the passion for people to fast, we need to give them the right information on how safe for them to fast. We are not trying to play a different role. We're not trying to be a doctor and an imam or a sheikh or a religious person. But equally, we don't want the medical advice to be coming from them. We want the imam to be an imam and a doctor to be a doctor. And in this situation, we need a dialogue between both. So I hope we don't run into problems again. Let me try. We've wasted a bit of time. I think I've gone through this. This is the data about type 1 diabetes between Morocco and Saudi Arabia. And this is the data about type 2 diabetes between, for example, Turkey and Malaysia and Bangladesh. But why is it important? The question of Akif. Because the data tell us that people who wish to fast, some of them, and I insist on the word some, not all of them, could be at the risk of these number of issues. Hypoglycemia, hyperglycemia, ketoacidosis, and the possibility of dehydration and thrombosis, especially in hot weather. If you look into the data of severe hypoglycemia that led to hospitalization in EPDR study, this increased about 5-fold in type 1 and 7.5-folds in type 2. Now, in the data that we did in UK and London, we looked into a small group of people with type 2 who were on oral therapy. And their control was not too bad. HbA1c was 8.2, as you can see. And those who decided to just carry on and do nothing, not attend any education or anything, the risk of hypoglycemia increased 4 times. In another study which we did in the same area, we looked into still getting the control better, but as people with type 2 diabetes on oral therapy control got better, the risk of hypoglycemia also increased 3.5 times. This is one of the studies done in 5 different countries and published 2 years ago, and looked into people with type 2 diabetes on sulfonylurea and metformin. And as you can see here, the variability of hypoglycemia varies massively from a country to country, from as low as 10% in Saudi Arabia to as up to 40% for Muslims living in Israel. So that is huge variation, although it's the same year and the same type of treatment. Now, Akif kept saying that Gaziantep is the country of, or the city of baklava, and obviously in Ramadan the behavior of people change a lot. Many people, after a long fast, they end up eating a lot of food, a lot of high sugar and high fat food, and a lot of sugary drinks as well. So the fasting all of a sudden changed to feasting, and we have a celebration every day for 30 days. And that risk was also studied, and in type 1 diabetes it increased 3-fold, which is high blood sugar levels that led to hospitalization with or without ketoacidosis, and in type 2, 5-folds. So we need to be careful with this, as it's obviously a behavior problem. Because of this, there's been many recommendations. The first global recommendations were from the ADA in 2005, and I have been lucky to be part of the authorship for this. And then came the second update for it in 2010, a British paper as well as a number of other British papers. And I throw in here even the data for the paper from Sudan. Not that because Sudan is a well-known, high academic country, but for the stress of the point that every country needs to look into international data and modify it for their own local requirements and culture. Now, the ADA recommendations subdivide people with diabetes into 4 different risk categories. The first very high risk category is people who the risk of hypoglycemia is very high because maybe of hypo-unawareness, maybe of recent severe hypoglycemia, maybe also because of their type of diabetes being type 1 on insulin, or because of other medical conditions that they have which they make the risk of fasting during Ramadan very high. Pregnant women, for example, someone who is doing a very intense physical job and fasting and having diabetes. The second category would be the high risk, and this is the group of people with poor control, the people also who have other comorbidities such as cardiac disease or kidney disease, not necessarily to the stage of dialysis, but nevertheless high enough to give them risk from hypoglycemia. Also, if I am living on my own and with old age, so maybe if I now would have a hypo, someone would say to me, you look different, check your glucose. But if there is no one to tell me check, then that also could be another risk, which is basically the risk of my social circumstances as well as my age and my health. The low or the moderate risk are those who are well controlled on types of medication that the risk of hypoglycemia is very low. Now, the important issue here is to have the religious group in harmony with the medical advice. We can say whatever we want to say here as people with healthcare profession. But if I were to go to the mosque and the imam would say something completely different, then that will be the end of the story. Luckily, we have a document produced 4 years ago in Sharjah with the collaboration of the International Islamic Council and the Islamic Organization. They looked into the document we produced by the ADA in 2005 and accepted the document as it is. But they were able to say something even more strong. They were able to say, people with the first two categories must not fast, because the probability of harm is high. Because the Quran, Islam, like any other religion, does not advocate harming the body. And equally they said that people with moderate and low risk, they have no problem to try and fast. Of course, this is generalization, and we need to individualize the care. Every single person in this room is a different person. Maybe different because of their lifestyle, their health, many issues. So we need to try and to talk to people well in advance. Monitoring. Michael presented his information earlier today, looking into the huge advantage of having glucose monitoring. And not just glucose monitoring, but the interpretation of the information. Now, if I'm fasting for a large number of hours, I need to know whether I'm now hypoglycemic or not, or I'm close to hypoglycemia or not. And indeed, after finishing the fast and getting into the big feast, I need to know whether I will be hyperglycemic or not. So this is essential for a person during Ramadan, especially if they are on insulin for sulfonylurea, but I would generalize it to every single person during Ramadan to understand their habits and maybe change their behavior, or at least provide the information for the healthcare provider to modify the treatment. They must stop the fast when they are hypoglycemic. And although this comes as a fact or as obvious, the very recent data that we have collected and presenting next time in the IDF is saying to us 25% of people who are having a hypoglycemia during Ramadan do not stop the fast. And that obviously is a very good point of the importance of having structured education for the patients. I had one of my relatives saying to me, there was 1 hour left for iftar, for Maghrib. So I decided to go to sleep. I said to her, that could have been your last sleep. Luckily, her body can produce adrenaline, glucose, cortisol to get her out of the hypoglycemia that she had. Some other person might not be as advantageous as this. So knowing when to stop the fast immediately is a very important message for people who are wishing to fast Ramadan. This care in general terms. And I'm sure that Michael's presentation, as well as the other presentation by Heather and Barbara, will very much encourage everyone about the importance of structured education. I personally, from my personal experience in many countries, find that in some countries, people with diabetes do not attend structured education as much. And I think that the passion for fasting might be a tool to encourage them to know more about diabetes in general terms. Now, the structured education for Ramadan is 3 levels. First level is a general awareness session, which could include media people, managers, imams, healthcare professionals, anyone at least to know what is the link between Ramadan and diabetes and fasting in general terms. The second part would be an intense, advanced session for healthcare professionals. The doctor, the nurse, the dietitian, the pharmacist. What should they do with various people who wish to fast on different types of medication and different comorbidities and different lifestyle? And then the most important part, a program that is designed to cover diabetes and Ramadan, for the patients to attend and to know more about how can they best manage this. Now, I'm going to give you some of the recent studies that has happened in Ramadan on how can we make the journey for a person a bit safer. Now, sulfonylureas as a class of drug are very good and very effective. However, because of their mode of action, if you're not eating, you could be at the risk of hypoglycemia. I know that glyburide or glibenclamide is very popular in the States, but it's the worst of the sulfonylureas in all of the studies. The risk of hypoglycemia with glibenclamide is much higher than other sulfonylureas. Up to 30% of people on it would develop symptomatic hypoglycemia. This was also echoed in another study which looked into different hypoglycemic drugs, and as you can see, glibenclamide was the highest, gliclazide and glimepiride were the lowest. And because of this, we started thinking of maybe we can use drugs with a pharmacodynamics that could be less risky during Ramadan. We did the first trial in London looking into the effect of vildagliptin, which is one of the DPP-4 inhibitors, one of the incretins, added to metformin. And this equally reduced the HbA1c and was not harmful for weight. What was hugely different between the group who were on vildagliptin and metformin compared to the group on sulfonylurea and metformin is the risk of hypoglycemia. 12-fold difference between the two groups. And that was a small study, which was the ammunition for me to convince the company to go to do vector study. Vector study was done in UK still and looked into people with type 2 diabetes on the same type of treatment, metformin and sulfonylurea, compared to vildagliptin and sulfonylurea. And as you can see from the study here, that those on sulfonylurea had hypoglycemia, which was not there when they were on the DPP-4 inhibitor vildagliptin. The risk reduction was 41% and was statistically very highly significant. And the beauty is this happened while the glycemic control improved. So many people can reduce their medication and eliminate or reduce hypos. The beauty here that was the magic combination of the two. You reduce the HbA1c from 7.7 to 7.3 and in this study no hypoglycemia. So that was a very good outcome. Now people said, well, this study was done in UK on a small group of patients from one background. What happens if we can repeat the study from many other countries? And as you can see, when the study was repeated and presented this year into the ADA, it included people from various countries. And the risk of hypoglycemia was equally reduced to 5.5% on vildagliptin, and while in sulfonylurea was 3.5 times higher. And this was happening with a weight reduction, but also with reduction in HbA1c. The HbA1c in the study also improved by 0.5%. What about if the patient is on insulin, already on insulin? Now, we did a small study looking into some people who are having a huge amount of carbohydrate at iftar time, large amount of rice, large amount of bread. And they were, before the study, on twice daily mixed 30. And we thought that if we change the iftar, the evening meal insulin, from mixed 30 to mixed 50, that might be more logical because of their type of food. I'm not advocating that we do this for all patients. It is for the selected person whose meal is very rich in carbohydrate. And in this, we've managed to improve HbA1c, but more importantly, it was matched with a reduction in hypoglycemia as well. There was a recent study on liraglutide, which also had some improvement. I don't have the full reference for this yet. What about a person on type 1 diabetes? Now, a person with type 1 diabetes, based on the recommendation of the ADA, as well as the recommendations from the International Islamic Fiqh Council, they should be advised, they should not fast. However, our job is to help anyone. If they insist on fasting, then they really must be doing monitoring, and ideally, they should be on flexible doses of insulin to give them the best possible flexibility to match their glycemic control during the fasting hours and during the non-fasting hours. In general terms, insulin analogues have been shown to be better, whether they're short-acting analogues or long-acting analogues. The dose modification need obviously to be happening, so they would have their long-acting insulin at iftar time, and the dose will be reduced if their control is tight by 20%, give and take, depending on the actual lifestyle and the control of the person. Premixed analogues, as I said, they were also shown to be better, and we did one study on the high mixes versus the low mixes in those with high carbohydrate intake. Insulin pumps is very good opportunity if the patient is knowledgeable enough, wealthy enough, and their doctor is also wealthy enough and knowledgeable enough to provide them with this if it's service-free or if they will fund it themselves. There was one study done by Edinburgh, and it was published 3 years ago, which showed that the risk of this group of people, because of their passion and knowledge, during Ramadan, their hypos were less than before Ramadan. So passion and motivation is very important that we can utilize in the right way. But we have huge gaps between what we say and what happens in reality. What we say is one thing, and what happens in reality is a completely different thing. And that's why we wanted to do something. And there's no better example than the paper we did in East London on pregnant women during diabetes. Unfortunately, pregnant women in that part of London were asking the imam about their diabetes as much as they were asking their nurse and their doctor. Now, I cannot blame these ladies. I blame us, the healthcare professionals, because we should be proactive enough to advise every single female in the productive age on, you have diabetes. What should you do if it happens that you're pregnant and it's Ramadan? Because, of course, Islam exempts a person during pregnancy, and certainly pregnancy and Ramadan is double exemption. So we need to be more proactive, and that was a good example of the gap that we have between what we advise and what happens in real life. And because of this, we have established DAR, Diabetes and Ramadan International Alliance. I'm delighted that this has happened because throughout the last 9 years or so, going to speak to many people, everyone is doing something good, but everyone is working on their own. And we thought we need an umbrella to have all of us together. And this umbrella now has been established with the collaboration of the International Diabetes Federation, with the collaboration of the European Association in the form of the Education Study Group, as well as the Gulf Group and many other organizations. We had the idea about 11 months ago in December last year, and we had our meeting already in March. Why have we established this? Because we know there are so many people with interest, and we want to make a network of people with interest so that we can exchange ideas, exchange knowledge, exchange skills, and work together for a safer and a better understanding of diabetes and Ramadan. Now, someone suggested that this Ramadan or R should change to religion, and I entirely agree. Fasting is practiced by so many other religions, but because of Ramadan being 30 consecutive days, and because of the type of fasting, we decided to concentrate on this first, and then we can move on to other types of fasting, and indeed other religious activities that can affect a person's diabetes care. We had the first meeting in March in Manchester, in this lovely building, which is the British Muslim Heritage Centre. And as you can see, our Akif is one of the audience here, and we had the attendance of the president of the IDF and the president of the ESD, as well as many other people. I don't know whether Heather was in the photo at that stage or she came after we already took the photo, but certainly Heather was one of the audience as well. This is the building that we had the meeting, and that is the British Muslim Heritage Centre, and obviously a very fitting place for the purpose. I am delighted that many organizations are now taking the Ramadan into recognition. The ESD in their last meeting in Barcelona have put forward one of the sessions for Ramadan. I just came back from India on Monday morning, where the biggest conference for diabetes there, attended by 4,500 persons. I was personally invited as a speaker for that purpose as well. So I'm delighted that many are taking this idea into consideration so that we can make the Ramadan fasting a bit more better. We have structured education been established many years ago. We published the first paper on Ramadan education in London in diabetic medicine, and in this paper we invited people to attend one single session of an hour and a half or 2 hours. And in this, the people who attended, their hypoglycemia risk was reduced from 9 events before Ramadan to 5 events during Ramadan. So while fasting during Ramadan, their hypo events better than before Ramadan. Because of what? A clever drug? No. A clever instrument? No. Structured education. While those who did not attend, their hypoglycemia risk increased to 36. So actually, the true difference is the difference between 5 and 36. So that is not 4 times increase, that is 7 times increase. And the stability of the information, that's what I said before. The Ramadan activity or education will give people knowledge for a long time. So their knowledge made their diabetes stable for 12 months. And I'm delighted that we won the Diabetes UK first prize in 2008 for this work, and the ESD for 2008, and the Diabetes UK for 2009 because of the sustainability of the treatment. Even though this was a single session that wasn't terribly structured with a program that is very robust. Having said that, we now have 3 different programs. We have a program done in UK with collaboration between Desmond Group and myself. We have a program done by the IDF, supported by Lily, the Conversation Map, and we have a program in Arabic that we've established in the Middle East for this year called Madar. I can tell you slightly about it. The word Madar in Arabic and in English means the same, or what we put, which is measured approach for diabetes and Ramadan. That has the support of the desk, the ESD, as well as the Gulf Group, and that was initially funded from Central Office of Sanofi. I love this photo because it can tell you the passion of the person giving the education, and also the sincere gratitude in the body language of the individual. Even though, obviously during educational sessions in many places, such as here, you have the opportunity of a blood test or so forth. And as you can see, this person was having his blood pressure checked. We had the sessions done in 4 different countries, in Egypt, in Saudi, in UAE, in Kuwait, and in Qatar. So actually 5 countries. And the variations in maybe the facilities, as you can see, the facilities in the center in Kuwait, top level, in other places could be simple. But that's important because education could be done anywhere. Education could be done in a park under a tree. Education needs to be delivered anywhere. And we have a presentation in the IDF about this data. What the data tell us that the majority of people did not have previous focused education for Ramadan. And the majority did not have any change to their medication. And only 60% were doing blood glucose, and most of them were doing it when they really were unwell, because the frequency was mostly 1 or 2 times during the month, rather than on a regular basis. The frequency of symptoms or actual hypos was 35%. And the timing of the hypos was mostly at the end of the day, when the glucose reserves are getting exhausted, which is very important for us when we are modifying our treatment. And unfortunately, what I said to you before, in this small group from Saudi Arabia, 23% of those who had a hypoglycemia did not stop the fast. So you imagine that I'm hypoglycemic now, and I carry on until maybe the lunch break. So that obviously is a serious concern. You can use lots of venues and lots of facilities. This program we did, which is available for you to watch if you wish on this website, or simply if you write Diabetes and Ramadan on YouTube and you will be able to see it. There's a GP here, there's an imam, there's a pharmacist, there is a doctor in education, in instruction education, there's a Diabetes UK representative, and there was a person from media as well. It's important for people to listen to the views of various multidisciplinary experts in the field. You need to use the internet, the media, so that the information can get to the people everywhere. Not necessarily face-to-face. The face-to-face would be the final part of it. And as I can say, if you log now and you say Diabetes and Ramadan on YouTube, you will end up with me a fortune. Now, the internet and social media has been really very important here. And DAR, as an organization, is very interested in this. We are planning a website, which will be for healthcare professionals, but also considering a chat type of website for people with diabetes. We are now talking to, sorry, I went too far. We're talking now about blogging. One of the colleagues blogged Diabetes and Ramadan event, and she tells me that 10,000 persons were following this. I yesterday had an email from the States, from the USA, about the webcast I did 3 years ago, and they are saying to me, this webcast keeps being downloaded. Is there a need to update the information? Can we print out for, because people are wanting this? So we're also talking to the mobile companies about a mobile application for advice for people to come to them in their own mobile phone about simple messages that will help fasting and Ramadan and diabetes. And then eventually, hopefully that will progress to mobile education for diabetes in general terms. But we have a big gap in studies. We don't have enough information. We have recommendations. We don't have guidelines. The difference, obviously, is in the level of evidence. And we have the need for looking into different regions. What's the difference between a Turkish Muslim and an Indian Muslim? What's the difference between a Turkish Muslim living in Turkey and maybe living in Germany or Holland? What's the difference between different types of diabetes, different comorbidities? And indeed, we want the studies ideally to be independent rather than just pharmaceutical studies. The Ramadan and Muslims are all over the globe. You would be surprised that India is the third country in the world with Muslim population. That the Muslims in Russia equal the Muslims in Syria and Libya together. I'm told that, for example, in Germany, that the number of Muslims in Germany equal the number of Muslims in Lebanon. So Muslims are all over the globe, and we need to try and reach them, especially when it's a country such as Turkey, a country that is rich in history, rich with its population, rich with academia. Now, I did this copy and paste in the earlier presentation from the IDF. The IDF last year says that Turkey has 3.6 million persons with diabetes, and undiagnosed, the last column here, 1.3. So you hardly have 5 million persons with diabetes, and you have the wealth of knowledge, and obviously Muslims are the majority in the country. So Turkey certainly could play a huge role in enriching the evidence-based and the knowledge that we need. I would just like to finish with my closing remarks. The Quran and the teaching of the Prophet Muhammad are very clear. They exempt some people because of their risks during fasting. Many people, despite all the advice, they insist on fasting. We need to make the decision a personal decision, but giving the person all the information, exactly like at the tobacco or the cigarettes pack when it says smoking can cause disease or smoking kills. Now, if I decide to smoke, I'm already been informed and I take my own risk. Those who insist on fasting, they need a consultation with their healthcare professional well in advance. Ramadan doesn't come as a surprise. We all know Ramadan 2014 is in late June. So we need to try and reach these people well in advance. Give them the right information, give them the right monitoring, adjust the treatment, give them the right education so that they can do this safely. The practice of so many of us that we simply reduce the insulin and the sulfonylurea dose, regardless of the level of control, is a wrong practice, and it needs to be measured according to the person's needs. And eventually, we have very little data, we have very little evidence base, and we really need to get more. I invite you all to come to share your knowledge and your skills for the second Diabetes International Ramadan International Forum meeting in Manchester next year. Thank you.